CS ma'am, who was mentoring us for so many years, almost 15 to 20 years in this field, and Dr. Suresh, Dr. Gupta, and Dr. Usha, and all the officials of VHS. Usha madam எல்லாமே சொல்லிட்டாங்க, நான் ஒன்றும் பெருசாக சொல்ல போகிறதில்ல. But what we do and what we feel as a challenge in implementing all those programs, and what is the way forward. This is a basic way in which we can address. And in fact, your concept of well-being exactly fits into this WHO theme of breaking the barriers and bridging the gaps. Tamil Nadu பொறுத்த வரைக்கும், we started this non-communicable disease way back in 2015 when Madam was a MD NHM. Or World Bank project, we could do it. And now with this government in 2021, we started this Makkale Thedi Maruthugam, where we do an active screening of the population, then give them a drugs, make them under control, then complication screening, all those being done. In fact, we have reached a level of now almost 49.62 lakh diabetes, we have a line list, and another 44.46 lakh people with diabetes and hypertension. So constituting 95 lakhs diabetic line list order Tamil Nadu. This is the load which we have right now. And we could able to provide the drugs at their doorsteps. What and all available in the private market, the latest drugs including Vida, we could able to give them free of cost at their doorstep. It's continuing. And in fact, for this massive achievement, ma'am, in 79 World Assembly, we got the UN awards for integrated task force. That's one of the government organization among the 17 organizations across the globe. This is all good thing which you have done, because it's basically we start working with the volunteers, women health volunteers, who are the grassroots level, who could reach each and everyone in the family. In fact, we have completed one round of screening across the state, except if you left out area, we could do it. And what we are trying to now focus is that there are special areas in which we need to focus, like pointed out by GDM ma'am, but before and after. Right now, we have a tracking of all mothers in a PICMI portal, which also developed with when Madam was PMD NHM. We have more than 2.5 lakh high-risk mothers right now. So with the different high-risk conditions, out of which, as on today, we have around 10,246 GDM mothers. See, the impact is this much big, and you all know the implications. Mother-ku varadu, mother-ku future-la varadu, baby-ku varadu, all those things are there. This we need to do it. The similar way, as I said, 95 lakhs, more than 2 to 3 lakhs, all the complications are going to come in future now. So, though we provide drugs to the doorsteps, there is a challenge in getting the, what we call it as a control, the glycemic control. So, if we try to reach them actively, screen them, put them on a drug, latest drug possible, follow the protocol, but still the glycemic control is the big challenge. We have two evidences. So one is that we have a step survey done few years back, and another recent step survey done recently in 2022 and 23, where still it is only the 19% of the populational control is under control, only 19. And the way in which there is an increase is that few years back it was around 11% of the community was diabetic, now it is more than 20. See, the prevalence is increasing, the community level control is coming down, even with all the things available at their doorsteps. And second part is that we thought we'll do a small peer group control. We thought the control will be better. Even in those peer group control, the control is only 59%. And again, the challenge is that those people who are not under control, they don't have a single risk factor. So always a multiple risk factor putting together, making things still worse. And this is the type of special groups you're trying to concentrate. Second part is your complication screening. Usual your retinopathy, nephropathy and neuropathy, we could able to do little big things. Like one is your, for retinopathy, we already established a TELV centers where in your block level PHC, we could identify all the long-standing uncontrolled diabetes, do them a screening, refer them for a next level of management. All those procedures are already covered under CM insurance, without any expenditure we can do it. And for a chronic kidney disease, CKD, which was one of the highest utilized package under CM insurance, we spend more than 120 crores in a year for CKD alone. See, this is the implications of your complications. For this also, what we thought right now do is a simple urine albumin testing for all the persons coming to PHC. It's a very simple test, cost few price, but once you suspect that, we have a little protocol where they'll go for a next level of screening with the creatinine. If needed, we'll go to the next level of nephrology, whatever it is. This is one part. And your neuropathy, which we were one of the major reasons for people getting disabled, amputations. This is another big challenge. They are not only getting affected individually, the entire family suffers because of this active age. And right now we started with a Padam Padagapatuttam, where at least to start with the visible ulcers, we'll treat them actively, bring the diabetes and control. At least we can prevent the amputations. This is another area which we're working on. See, with all these issues, as I said earlier, it is still not under control. So the control is the big problem. Unless and otherwise we bring down the glycemic control, the numbers which I said, 95 லட்சம் இவ்வளவு பேர் செலவு பண்றேன்றலாம் will not work. So this is where our real challenge which we need to address. From our limited understanding, we have 2-3 things which we should do. So as an individual level, we should start warning ourselves. See, unless and otherwise individual takes care of health, it's not going to be done. See, it's beyond the human capacity of the few institutions to take care of every individual. மற்றதெல்லாம் பண்ற மாதிரி, let us see, now the technology is there for us. You can measure your glucose by yourself. You can measure your exercise, what you walk every day, and you can able to measure what you eat. As you rightly said, ma'am, just we need to have a very clear understanding on what we eat. See, just calorie alone may not be sufficient. A calorie, protein, whatever it is, but there are now easy tools. We need not to be a nutritionist to understand everything. There are simple tools available free of cost, or even a small subscription where you can monitor what you eat. See, நம்ம என்ன தேவைன்னா நியாயமா என்ன பண்றோமோ அதை ரெக்கார்ட் பண்ண ஆரம்பிக்கணும். பண்ண ஆரம்பிச்சோம்னா definitely we know where we are going, how much calorie every day we are exceeding, and how much deficient protein or whatever it is. If you are able to do it, definitely over a period of time we can bring the control. See, this lifestyle modification should become an individual responsibility. See, this is where the IEC, NGOs, everyone has got a role. Unless this is done, whatever input we push in, we may not able to reach the real level of control or what are the complication prevention. So next is that there may be a little challenge where you may not have follow this adherence. To increase this, we are trying to bring in the peer groups. The peer groups, if you are able to create 1-2 interventions, we are trying in Viluppuram Kallur. So this is where they share their experience. மாத்திரை எப்படி எடுத்துக்கிறோம், எங்க மிஸ் பண்றோம், என்ன சாப்பிட்றோம், what is the recipe, where they are going wrong. See, all those things, if they are able to learn between the peers, and if they start walking together, working out together, the compliance is still better. This peer group is another area which we need to do it. And third big challenge is that this is not, we should start doing only after you get into the problem. See, we need to start reaching the adolescence. See, unless and otherwise you reach the adolescence, who are already varied BMIs, both low and low, and anemic, all stressed out, and educational peer or peer pressure, whatever it is. And if you add on to this metabolic disorders, they are landing into the adult age with all the complications, whether it is an NCD or your GDM, whatever it is. Unless and otherwise the adolescents are handled now, it will be very difficult. What we call it as, what you said is a Zomato, we call it as a commercial determinants. See, the commercial determinants is where the people, the adolescents are getting diverted. See, you are all sweet, sugar, trans fat. This is where the real addiction is there. The industry and the commercial establishment, for the various reasons, they could able to target this young generation, keep their balance sheet healthy. See, unless and otherwise you address these commercial establishments, commercial determinants, it's going to be the challenge. But it is our responsibility not only treat those people who are identified, but to prevent the younger generation getting into the problem. Once again, thank you very much for the opportunity. Thank you.